Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Lilly.
Hello, and welcome to the EHA 2024 recap, Optimizing the Relapsed Refractory CLL Treatment Pathway. My name is Jennifer Wyack. I'm a professor of medicine in the Division of Hematology at The Ohio State University in Columbus, Ohio. I'm joined by Professor Stefan Stilgenbauer, who is the medical director of the Comprehensive Cancer Center at Ulm, the head of Early Clinical Trials Unit, and the head of the Division of CLL. During this program, we're going to discuss the following. We'll talk about how we treat our patients with relapsed refractory CLL using the currently available second and third line treatment options and discussing options in the United States and Europe. We'll discuss key EHA 2024 updates and approved therapies for relapsed refractory CLL and how these could affect clinical practice. And then the latest EHA 2024 data on new and emerging therapies for relapsed and refractory CLL. Here you can see how the treatment landscape for relapsed and refractory CLL has changed very dramatically over the past decade with the introduction of targeted therapies for this disease. This started out with the Bruton's tyrosine kinase or BTK inhibitors ibrutinib, followed by acalabrutinib, and in 2023, zanubrutinib. We also have seen the rise of PI3 kinase inhibitors, idelalisib and duvelisib, although not used much in clinical practice anymore. And then in 2016, the FDA and EMA approval of venetoclax for relapsed refractory CLL. In the past year, there have been two additional therapies that have been approved by the US FDA, although not approved by the EMA yet. And these drugs are approved for patients with two prior lines of therapies that have included both a BTK and a BCL2 inhibitor. This includes the non-covalent BTK inhibitor pirtobrutinib and the first cellular therapy FDA approved for CLL, lisocabtagene maraleucel or liso-cel, both of which again approved in the same indication. One of the most important things when thinking about therapy in both the frontline and the relapsed refractory setting, because there are so many options, is shared decision making. So here, selecting a treatment is a shared process which involves both the clinicians and the patient, and in many cases also the multidisciplinary team, including nurses, nurse practitioners, and pharmacists, all of which the goal is to take fully into account the patient needs and preferences for their therapy. When we think about selecting the right therapy for an individual patient, we have a number of things to consider. One is the optimal sequence of available therapies. Again, we have a lot of options for patients with relapsed refractory CLL, and a lot of it depends on what sort of therapy they received in other lines. Patient needs and preferences in terms of things like transportation, concomitant medications, other medical problems. We have to think about adverse events associated with therapy and how this might affect an individual patient. And then, of course, when somebody has started treatment, we need to be cognizant of recognizing intolerance to therapy as well as disease progression. So here you can see a number of the therapies that have been approved and recommended as second-line therapy for relapsed refractory CLL. And on the left, you can see those that are approved in the United States. On the right, we can see those that are approved in Europe. So starting with the therapies that are approved in the United States, we have the covalent BTK inhibitors, ibrutinib, acalabrutinib, and zanubrutinib. We have BCL2 inhibitor venetoclax, and this can be combined with rituximab. It can be used by itself. And in the NCCN guidelines, venetoclax is recommended to be combined generically with anti-CD20 monoclonal antibodies, which would then allow the use of obinutuzumab in the relapse refractory setting. Then again, as I mentioned, we have the non-covalent BTK inhibitor pirtobrutinib, which is recommended by NCCN for patients resistant to or intolerant of prior BTK inhibitor therapy. Outside of the United States, we have a number of these same options available. Again, the covalent BTK inhibitors, ibrutinib, acalabrutinib, and zanubrutinib, and then the BCL2 inhibitor venetoclax, specifically combined with rituximab. Now we're going to look at the therapies that are recommended after patients have received both a BTK inhibitor and a venetoclax-based regimen. So primarily, these are going to be third or later line therapies. Again, we have this broken down into options recommended primarily by the NCCN in the United States and those recommended outside of the United States. So again, for patients who have received both a prior BTK inhibitor and prior venetoclax, in the United States, we have the non-covalent BTK inhibitor pirtobrutinib approved. We have liso-cel as well. We have PI3 kinase inhibitors. Again, because of toxicity, these are not used all that often right now. But we do have available idelalisib, which can be used with or without rituximab, and then duvelisib as well. We also have some combinations. So bendamustine plus rituximab is still listed in the NCCN as one of the possible options, although really in most cases, this isn't going to be an effective therapy, similar to with FCR. Chemotherapy in general does not tend to work very well after targeted therapies. Also recommended by the NCCN guidelines is a combination of ibrutinib plus venetoclax. Even in patients who are resistant to both a BTK inhibitor and to venetoclax, it's been shown in retrospective studies that patients can still achieve a remission with the combination of ibrutinib plus venetoclax. And in some cases, this can actually be quite a durable remission, although primarily it's intended to be used as a bridge to the next line of treatment. Obinutuzumab by itself, CD20 monoclonal antibody, is another option. And then, of course, allogeneic stem cell transplant, although not used all that often in the United States at this time, certainly should be considered for those patients who have progressed after treatment with a BTK inhibitor, a covalent BTK inhibitor, and venetoclax. And then for all patients at all lines of therapy, clinical trials are both appropriate and encouraged. In the setting of patients treated outside of the United States, again, many of the same options are available. There's maybe a little bit less flexibility in terms of the options that are approved in the front line being moved to the second line, or I'm sorry, the third line setting. However, the PI3 kinase inhibitor idelalisib, given with rituximab, is still an appropriate choice. Chemoimmunotherapy, again, probably not a very effective option in this setting, but FCR, bendamustine plus rituximab, or chlorambucil plus obinutuzumab. Allogeneic stem cell transplant, again, especially in patients who have limited therapeutic options, should really be considered in this setting. And then, of course, clinical trials, again, should be encouraged for all patients. So now I'd like to move on to some cases, and we're going to start with Tom. Tom is a 72-year-old man. He is living in the United States and has CLL. He presents to the clinic with fatigue, a rising white blood cell count, decreased hemoglobin, and palpable lymph nodes. He was diagnosed initially with CLL 8 years prior and received frontline therapy with venetoclax plus obinutuzumab a couple years after his diagnosis, so he completed therapy 5 years ago. A CAT scan reveals enlarged cervical and axillary lymph nodes along with splenomegaly. On review of his prognostic studies, he has unmutated IGHV and does not have either a 17p deletion by FISH nor a TP53 mutation. Looking at his other medical issues, he has hypertension and hyperlipidemia, and currently only takes lisinopril and atorvastatin. So now we're going to have some interactive polling. What do you think would be the most appropriate next treatment for Tom? Would you retreat with a venetoclax-based therapy? Would you start fludarabine, cyclophosphamide, and rituximab, or FCR? Would you start a covalent BTK inhibitor? Would you start pirtobrutinib? Would you start liso-cel? Or would you do an alternative therapy to any of these listed? And there's really not one specific right answer here. All right, so let's see what people thought. The majority of people agreed with starting a covalent BTK inhibitor. That was 46%. 17% participants recommended liso-cel. 13% recommended pirtobrutinib. 9% recommended an alternative therapy. 7% each suggested either retreatment with a venetoclax-based therapy or start fludarabine, cyclophosphamide, and rituximab, or FCR. So let's think a little bit about these options. Again, there's not really one right choice here. I think, for this patient who has only been treated with venetoclax, while, something like liso-cel on a clinical trial would certainly be appropriate, it wouldn't be under the FDA label, the accelerated approval label for that, nor pirtobrutinib either. I think, FCR could be considered. However, this patient is relatively old to be treated with such an aggressive regimen. We know that even in the frontline setting, FCR is not superior to bendamustine rituximab for those patients over the age of 65. And as well with the unmutated IGHV status, we wouldn't expect that we would see a very long remission duration with that. Certainly there are some alternative therapies that could be considered, and especially, novel things on clinical trials or new combinations. So that leaves, I think, that probably the two answers that are likely to achieve the longest remission, and that would be either a covalent BTK inhibitor or even retreatment with venetoclax-based therapy. So, the venetoclax-based therapy, I think, is an okay option for this patient. He's had 5-year remission duration. One might imagine that the remission duration with retreatment with venetoclax is likely to be shorter. Though most people, I think, would use 2 years of venetoclax in this setting rather than the 1 year that he received in the frontline therapy. And then, of course, you could either do rituximab or in the US, you could consider obinutuzumab as well. There's actually a trial that's ongoing looking at this approach. It's called the Revenge study, which is using retreatment with venetoclax obinutuzumab. So hopefully in a few years, we'll have some results on whether that is a good therapy for people like Tom. A covalent BTK inhibitor, of course, is probably the most standard answer here and something that is very likely to achieve a long remission duration. So this is Carolina. She's an 82-year-old woman. She has CLL and she lives in Europe. On prognostic study, she has an unmutated IGHV and she has a deletion 17p and as well a TP53 mutation in the alternate allele. She was initially diagnosed with CLL 3 years ago. However, 10 months ago, she started having fatigue along with a rising white blood cell count, decreased hemoglobin, palpable spleen, and she started ibrutinib monotherapy to control these symptoms. She presents today with a wish to stop therapy due to worsening arthralgia and myalgia, as well as difficult to control hypertension since she started the ibrutinib. Up until this point, though, she's had an excellent response to therapy. So what do you think would be the most appropriate next step for Carolina? And again, there's not really one specific right answer here. Would you reduce the ibrutinib dose along with supportive measures? Would you start pirtobrutinib? Would you start liso-cel? Would you start acalabrutinib or zanubrutinib? Would you start venetoclax plus rituximab? Or would you do something different? I think it looks like the results were pretty split here. There's about 20% of people suggested reducing the dose of ibrutinib. Almost 30% would start acalabrutinib or zanubrutinib. Another 20% would do venetoclax rituximab or pirtobrutinib. And then a few less would do liso-cel or would do an alternative therapy. I think in this case, certainly reducing the ibrutinib dose along with supportive measures, I think would be a reasonable thing to do. Honestly, what I usually do in practice would be to actually stop therapy in general. If I was planning on switching to acalabrutinib and zanubrutinib, I usually wouldn't start them right away. I would stop treatment, and then when we see disease progression, start acalabrutinib or zanubrutinib. But here I might reduce the ibrutinib dose as well. How about you?
Well, yeah, I think all of those are reasonable, very reasonable choices. Probably I would try to remain on one treatment principle. So either dose reduce and have supportive measures with ibrutinib, or switch to a second generation covalent BTKI, such as acalabrutinib or zanubrutinib, and rather save other treatment principles, such as a non-covalent BTK inhibitor, such as pirtobrutinib or venetoclax-based treatments for later. This be my approach, I think, but there's a choice, certainly.
Yeah, it certainly wouldn't be inappropriate to start venetoclax plus rituximab, but I agree. I would also try to stick with the covalent BTK inhibitor class until you know it doesn't work anymore. So our last case is Andrew. Andrew's a 77-year-old man. He lives in the U.S. and was diagnosed with CLL 12 years ago. He initially became symptomatic 7 years ago and was treated in a clinical trial with acalabrutinib. 2 years into treatment, his white blood cell count started to rise, and he developed palpable lymph nodes. He was felt to be resistant to this initial treatment, and therapy was changed to venetoclax plus rituximab. Completed this therapy, and 4 years later, he presents with lymphocytosis, decreased hemoglobin, and enlarged lymph nodes. So what would you do for Andrew? Would you start pirtobrutinib? Would you start liso-cel? Would you start idelalisib plus rituximab? Would you enroll the patient in a clinical trial? Would you prepare the patient for allogeneic stem cell transplant? Or would you do something different? All right, Stefan, what would you do in this case?
Right. I mean, this is obviously one of those few but unfortunate scenarios where the great treatment options that we have failed. Fortunately so, we in the US at least have pirtobrutinib and liso-cel licensed in this situation. I think with a larger patient number and easier access, I think is probably what is favoring pirto in this situation here. Although liso-cel obviously is also a promising option, enrolling a patient on a clinical trial obviously is always a very good choice because it offers yet other options. I wouldn't be so much in favor of idelalisib-based treatment due to the limited activity and in particular the adverse events that we've seen with this agent.
Yeah, I agree. And I think also, he's 77 years old, so probably a little bit old for an allogeneic stem cell transplant. Although I guess it could be considered in centers that have expertise in that area. I would think, I think I would probably do pirtobrutinib as well. Although if I was going to ever give this patient liso-cel, this is probably the time I would do it. Assuming that pirtobrutinib is going to give about a 1.5 to 2 year remission duration, he would be 79 at that point. And I think you're going to show us some data in a little bit that suggests that number of lines of prior therapy might make a difference in terms of response to liso-cel. So if he was very healthy, very active, and wanted to do something more aggressive, I might consider that right now too.
Absolutely.
Okay, so now we're going to move on to some of the updates from EHA 2024, and I think I'm going to turn it over to Stefan right now.
Yeah, thank you very much, Jennifer. So although the key topic and theme that we follow here is treatment of relapsed refractory CLL, there have been some interesting frontline updates that may illustrate how we treat patients in the future also. One trial that was interesting was the combination of zanubrutinib plus venetoclax for treatment-naive patients with high-risk genetic characteristics such as 17p deletion and p53 mutation. And this combination in a single-arm, limited patient number trial showed to be very effective and very well tolerated. So promising option that has to be evaluated further in future trials. Now, another trial evaluated ibrutinib plus venetoclax compared to FCR in untreated CLL of intermediate risk. It was a FILO trial that also indicated good outcomes with ibrutinib plus venetoclax treatment, although at the cost of some cardiac toxicity that we have seen with this regimen. An interesting point presented from your group, Jennifer, was a very long-term follow-up of the triplet combination, obinutuzumab, ibrutinib plus venetoclax, presented by Kerry Rogers. And the triplet regimen, obviously of a fixed duration treatment type, showed very good lasting responses, and the 7-year update indicated that with this limited duration treatment, these patients can enjoy many years of treatment-free interval, which is obviously a good thing. And last but not least, Ned and Jane from the MD Anderson Cancer Center showed data on a very novel combination using the non-covalent BTK inhibitor pirtobrutinib plus venetoclax plus obinutuzumab in the frontline setting, indicating that with this regimen you can achieve a high rate of undetectable minimal residual disease, so a promising regimen to be taken forward in future trials. So with this, we come to the update from the trials in the relapsed refractory setting, and I hand back over to you, Jennifer.
Okay. So the first abstract we want to discuss in these approved therapies is an update from the phase 1/2 Bruin study of pirtobrutinib in CLL. What was presented at EHA this year was specifically focused on the BTK inhibitor naive cohort, which was a small cohort of only 35 patients out of the entire study, which was almost 800. So looking at the efficacy in this patient population, as expected, given the results in the study as a whole, patients who had never been previously exposed to a BTK inhibitor did extremely well. Again, a small patient subset, but the overall response rate was 91.4%. One patient had a complete response, but as expected as well, most of these responses were partial responses. And you can see from the waterfall plot that many patients had almost all, if not all, of their lymphadenopathy resolved. We also see that the responses are not dependent on genomic features like TP53 alterations, mutated IGHV, or complex karyotype. When looking at progression-free and overall survival here, the results again are very promising. So median PFS is not yet reached, and at 24 months, about 75% of patients remained in remission. At the same time, 88% of patients remain alive, and again, the overall survival is not yet reached either. When looking at safety, the results in this patient group are pretty comparable to the entirety of the group of patients on this study, where side effects were fairly minimal in number, and most of the adverse events were of low grade. We can see some of the adverse events that are seen in higher grade, actually neutropenia, which I think was a little bit surprising. I think most of us thought that this was related, again, to these patients being very, very heavily pretreated. This is a less heavily pretreated group of patients, and we still see about a third of patients with grade 3 or higher neutropenia. And then other things just in small numbers or low grade, like bruising, diarrhea, anemia, and fatigue. And now with the lysosel study.
Yes, thank you, Jennifer. So we touched upon the lysosel data. Lysosel was licensed in the third-line setting by the FDA based on the Transcend 004 study. And at the EHA meeting, Bill Weirda from the MD Anderson presented a prognostic marker analysis looking into factors associated with efficacy and also adverse events in the Transcend 004 study. So as you may remember, 137 patients were enrolled in this trial. Due to the manufacturing process and the way to infusion and response assessment, only 87 patients made it to the response assessment, and this efficacy evaluable set was the basis for this correlative marker analysis. Overall, among these 87 patients, there was an 18% CR rate, and these CRs appear to be durable with good PFS and OS times in this very refractory, heavily pretreated population. Now, when looking at the usual genetic characteristics, such as unmutated IGHV, deletion 17p, TP53 mutation, and complex karyotype, you see that the outcome was not really affected very much by these parameters, indicating that high-risk genomic markers are probably not the risk factor to look at with this type of treatment. Also, age was not correlated with response. However, when the investigators looked at the number of prior lines, and you have alluded to that, Jennifer, not surprisingly so, it looked like the higher the number of prior lines was, in this case more than 3, the worse the outcome was. Similarly, bulky disease, so lymph nodes over 5 centimeters in diameter, and also advanced dry stage, was associated with inferior responses, so apparently somewhat reduced efficacy. Also interesting is obviously when looking at the adverse events that we have this with this type of treatment, you know, that cytokine release syndrome and neurologic events are the acute toxicities that we fear with this treatment. And it looked like renal insufficiency and inflammatory markers measured here by the CRP and ferritin levels were somewhat associated with an increased incidence of neurologic events and CRS. So interesting analysis based on limited patient numbers that may help us guide this very specific type of treatment in a patient population in the future. Larger numbers, longer follow-up of this analysis, also with regard to PFS and OS, is needed, I think. And with this, hand over back to you, Jen.
Yeah. So I guess we can take just a moment to give kind of our one-liner on how we think that these updates have changed our current practice. I think that the pirtobrutinib data is interesting. We would expect it's going to work better in patients who have not previously received a BTK inhibitor, but it's nice to see that's the case. I think the liso-cel data was interesting because it is helping us understand who are the patients that are best, that are most appropriate to receive this regimen, who's going to get those complete responses. And I think that we're getting closer to that, but not quite there. Any other thoughts on that, Stefan?
No, I agree. I mean, these are still small numbers. What I find a bit unfortunate is that the liso-cel analysis was based only on the patients who made it to the final response assessment. There were some patients obviously progressing earlier than that, or even receiving the product, but not making it to the response assessment due to adverse events or disease progression. And to me, these possibly would have been informative as well to analyze. So I think we need longer follow-up and more higher numbers to make more out of this analysis.
Yeah, I completely agree. All right, so let's move on to some of the novel and emerging therapies. And actually, I'm going to have Stefan take this abstract.
Right, so there was interesting data presented with a next generation BCL2 inhibitor called sonrotoclax, combined with a second generation BTK inhibitor, zanubrutinib, in relapsed refractory CLL, obviously heavily pretreated cohort of patients with this experimental regimen. There was a ramp-up dosing with the sonrotoclax to avoid the usual issue with BCL2 inhibitor of tumor lysis syndrome, and then there was a combined treatment with both agents. Now, when looking at the adverse event profile seen with these two agents, you see some expected features in the full cohort and in the combined cohort. Contusions and other adverse events like diarrhea that we may see with a BTK inhibitor were observed, but they were mostly low grade, and actually neutropenia was the only more frequent adverse event that occurred at a higher grade, as you see on this slide. So overall, to me, a very favorable adverse event profile. Only one patient discontinued zanubrutinib due to treatment-emergent adverse events, and one patient discontinued zanu plus sonrotoclax due to an adverse event. 51% of patients experienced grade 3 and higher adverse events, which to me in this patient population is a very favorable number. When looking at the efficacy of the regimen, here measured by the minimal residual disease status and overall clinical response, we see that there was a 97% overall response rate with a 57% CR rate across all doses, which to me in this heavily pretreated patient population is truly remarkable, similar to the very high rates of undetectable MRD that we see with this regimen. And not without a reason, this regimen therefore is taken forward in a frontline phase 3 randomized trial to establish this as a potential new standard of care. Obviously, we need data from this trial before we can draw final conclusions. Another interesting trial also presented not exactly in the relapsed refractory CLL ballpark, but for patients with Richter's transformation was the EPCORE CLL one trial, a trial of epcoritamab monotherapy in patients with Richter's transformation. As you know, a very, very dismal condition with no real standard of care. We used the R-CHOP regimen with suboptimal responses and suboptimal long-term outcome. And new agents are obviously urgently needed in this population. Epcoritamab was used at the mostly used regimen with a ramp-up schedule in the beginning to avoid IRRs, and was usually pretty well tolerated. On this slide, you see the overall response in the efficacy evaluable patient population in the first-line patients and in the relapsed refractory patients. And we see quite some responses, remarkably so with this monotherapy with a bispecific antibody. And in the waterfall plot, you see that the responses measured in the nodal disease are also quite impressive. When looking at the time-dependent outcome data here shown for progression-free survival on the left and overall survival on the right, we also see some efficacy. When you focus on the left panel, obviously the patients without a response had a very poor outcome, while the patients who responded or even had a complete response to that treatment fared favorably. On the other hand, these curves also indicate to us that epcoritamab monotherapy probably is not enough to achieve really long-term disease control in Richter's transformation, and not without a reason. Trials are underway evaluating epcoritamab in combination with other agents to further improve outcome in this very, very poor risk condition of Richter's transformation. Tolerability and safety on that trial was as expected. There were cytokine release syndromes, observed infections and cytopenias. Cytopenias were the adverse events that we saw at higher grade in this trial. ICANS, so neurologic events that we see with these agents, fortunately occurred at a lower rate and were usually manageable. So to me, these data indicate that epcoritamab has a role to be evaluated further in additional trials in Richter's transformation, most likely in combination with other agents. And with that, I hand over to you, Jen, again, to focus on some very interesting new small molecules.
Yeah, so I'm going to go through these relatively quickly, but there were updates on 2 of the BTK degraders in relapsed refractory CLL presented at EHA this year. The first is the NX-5948, and this is the selective BTK degrader that does not degrade Ikaros and Aiolos. It doesn't have any of those IMiD effects. You can see it's being studied in both CLL and other non-Hodgkin's lymphomas. We're going to focus on the CLL cohort here. Looking at safety, this agent was very well tolerated in this small patient subgroup. In addition to the overall population, we see most of the side effects are low grade, and they include some of these BTK ones that we're familiar with, like bruising and bleeding, fatigue, petechiae, rash. Higher grade toxicities included neutropenia, which kind of also followed to the bigger patient population. Looking at the waterfall plot, we see that most patients did achieve a response in terms of their lymph node shrinkage. Overall response rate at this time is 69%, all as we expect for partial remissions. And you can see that most of these patients are still ongoing in their treatment. So we don't really have a lot of long-term data to understand how durable these are going to be, but it's looking very promising so far. The other BTK degrader that was presented is BGB-16673. Again, similar, this is a selective BTK degrader. It's being studied in CLL as well as other B-cell malignancies. Here we have 49 patients with CLL that have been treated, and we can see the treatment-related side effects are relatively low. Again, most of the side effects have been low grade. When we're looking on the right side in terms of the more common side effects, we see, again, things like bruising, some low-grade bleeding, diarrhea, some cytopenias. Higher grade toxicities include neutropenia, again, similar to the other compound, and then pneumonia was seen relatively frequently in this study. Looking at responses, we see that the overall response rate is 72%, again, mostly partial responses. Follow-up, again, is relatively short. It's 4.9 months, but many of the patients continue on treatment. So it'll be exciting to see what this looks like when we have longer follow-up over the next few meetings. So then I'm going to turn it over to you, Stefan, for the concluding remarks.
Thank you, Jennifer. So all in all, I think it is evident from the data that we have shown here that when we look at relapsed refractory CLL, in the case of progression after frontline venetoclax plus obinutuzumab treatment, we do have obviously two well-established options, either venetoclax-based retreatment, likely combined with rituximab in this setting, and you would do that if there was a long initial response, or treat with a covalent BTK inhibitor, more likely in patients who didn't respond for such a long time. If there is progression after frontline covalent BTK inhibitor treatment, we can either switch to venetoclax-based regimen or, based on the NCCN guidelines in the US, to a non-covalent BTK inhibitor, pirtobrutinib. In case of intolerance to frontline covalent BTK inhibitors, we can either switch, which will most likely be ibrutinib, to a non-covalent second generation inhibitor such as acalabrutinib or zanubrutinib, or switch to venetoclax-based therapy. Now, the more difficult scenario, and I hope we were able to outline this to you, are the patients in the third line setting, patients who have failed a covalent BTK inhibitor and who have failed BCL2 inhibitor, mostly venetoclax-based therapy. Now, in the US, we have the non-covalent BTK inhibitor pirtobrutinib and CAR T-cell therapy with lysocell available after for these patients, which unfortunately so is not the case in Europe, where PI3K inhibitors or chemoimmunotherapy are the option that we have available for these patients. In this population, obviously, further developments in clinical trials of BTK degraders, of bispecific antibodies, and novel combinations are urgently needed. And I think, Jennifer, you very nicely outlined the data that we've seen, in particular with the degraders, but also with other agents that do look indeed very promising. And with this, thank you.
Thank you. It's a pleasure working with you. Thank you, everybody, for joining us today for this talk. Thank you very much.